First of all, thank you all for joining. Those who registered but are not able to join, you will get a replay link. And thank you to Hannah and Dr. Zietzer for allowing me to come in and talk for a little bit and just kind of share some tips and tricks that hopefully will change your practice. So just a brief introduction to me. I'm an emergency physician, been practicing for about 17 years. I live and work in South Carolina and heavily involved in the Urgent Care Association. That's where Mark and I met last summer in Nashville. I'm on the board of directors for the College of Urgent Care Medicine, creator of the Laceration course, and I've partnered with EB Medicine to bring educational content to a wider audience. So for today's talk, here are the topics and objectives. We're going to talk about all these things that are on here, but I really want you to be able to come away with some things that are going to make you more efficient, more confident, and hopefully be able to take better care of patients wherever it is that you are working. So we've got an hour that's blocked off. I don't have anything planned after this, so I'm happy to stick around later, answer any questions and continue the discussion, but I'm going to try to scuttle through all these as quick as I can, talk about some of the different products that we've got from EB Medicine, but most importantly, just to, to have a discussion and be available for question and answers. So as you all can probably imagine, it's not possible to cover every aspect of laceration management in a 1 hour discussion. It's kind of the tip of the iceberg. So what we're going to try to do is expose you to a handful of different things. And that's why I created the Laceration course, which is a 10-hour, very in-depth course that covers all aspects of acute laceration management. But before I get started, I want to introduce a case presentation. And throughout this webinar tonight, I'm going to go through this one particular case, and it's going to be kind of sprinkled throughout the webinar. So, working in urgent care, working in the emergency department, we constantly get interrupted. So I'm sitting here, I'm doing my thing, taking care of yet another respiratory illness. And lo and behold, I've got this elderly patient, 75 years old, who has a large laceration along the anterior aspect of her tibia. She was getting out of a car, the car door slammed on her leg, and she's got this big gaping wound. So what I want you to start doing is thinking about how are you going to approach this? What resources are you going to use? What tools, what supplies? Are you going to need imaging and things like that? So we're going to go through this case throughout the webinar, but that's the introduction, an elderly lady with a large laceration on her leg. So I want to introduce just some basic things, and we're going to talk about these kind of the approach to lacerations. You're working in a busy clinic. The last thing that you want to have to deal with is a large laceration that comes in. It puts everything just to a grinding halt. So we're going to talk about the approach. We're going to talk about suture material, the instruments that we're using, and a new approach to the digital block. So over the years, I have become more efficient. And I think that that's something that just takes time, experience, a lot of failures, and learning how to be intentional. So I'm not going to sit here and read everything that's on this slide, but how I approach things in the emergency department, I think it's very applicable to urgent care as well, is whenever you see a patient who checks in, or maybe somebody from the front office calls, hey, we've got a big laceration here, go ahead and start thinking about what you're going to need and what you are going to do. When you get in the room, of course, you want to go through the ABCs, airway, breathing, circulation. If there's a more significant injury going on, don't ever overlook the basics. And that's with your ABCs, getting your history. Are there any other injuries that you might be contending with? Go ahead and start putting in orders, order your x-rays. After you get a look at the laceration, you're probably going to know what you're going to need. And I'm a big believer in going ahead and getting all those supplies myself, not relying on an assistant or a nurse or a tech or somebody else to go do it, because lo and behold, they're going to overlook something and that's going to slow me down. So I can take 1 minute, go grab what I need, get it set up, and then I'm going to anesthetize the wound. That gives you a little bit of time while you're waiting for the anesthetic. You can leave the room, go chart, go see another patient, go discharge somebody. All the while the patient's sitting there, their anesthetic is kicking in. You can come back in the room, you can irrigate, or even better yet, if the wound is amenable to it, they can stand at the sink. That buys you a few extra minutes, again, to go chart, see another patient, disposition somebody. All things that really can say, over the course of a shift can add up and save you some valuable time. Another important thing is when you're actually repairing the wound, go ahead and talk to them about the discharge instructions. You can go through your whole spiel, you can answer any questions. And what that does is that it prevents you from having to come back in and talk to them later. Again, being efficient, being intentional, anything that you can do to avoid any unnecessary trips in and out of the room. It's also, to be mindful of what's going on in the clinic, having a handle on patients that are coming in who are ready for discharge. Really just, being mindful of your surroundings. If it's very busy and you've got a large laceration, you may have to stop in the middle of it and go tend to what's going on in the clinic. So I include this because these are things that I've learned the hard way, and just want to share those with you to hopefully, improve your efficiency. So in the preparation for this, the spreadsheet that was sent over for registration, there were a lot of really good questions that came across, and I'm going to address those at the end. But one of them was, can you talk about suture types? Now, some of this stuff is pretty basic, but I can speak for myself. A lot of this stuff I didn't really have a good handle on until I put the laceration course together. So I want to include those here. So when we're looking at suture types, we're really looking at two main classes, and that's absorbable and non-absorbable. Now, for the most part, we're trained and we probably have the most experience with our non-absorbable, the ones that are on the right. And the two main ones that we use and that we probably have familiarity with are Ethilon, which is typically colored black, and Proline, which is typically colored blue. Those are the main non-absorbable sutures that we're using. They're a monofilament. They're almost like a fishing line. On the other side, we have our absorbable. Those are ones that just by their chemical makeup break down over time. And we've got braided and monofilament. So your braided, like a Vicryl or Vicryl Rapide, sticks around longer. Those are great for deep sutures where we need to provide some strength and we don't want it to break down after 4 or 5 days. So for your deep sutures, ones that you're really trying to close up deep space and provide some longer lasting hold, Vicryl is a great option for that. On the other side, sometimes we don't want that suture to stick around for 14 to 20 to 30 days, and we want something that will dissolve and degrade and break down quicker. And that's where you have like a monocryl, a fast absorbing plain gut, or chromic gut for sutures inside the mouth. There's a lot more advocacy now for using absorbable sutures externally on the body, on the face for pediatric patients. So a fast absorbing plain gut would be a good suture to have. If I had to pick 4 sutures, this is what I would be choosing to stock in my urgent care or emergency department. And since I can't see all the participants here, if anybody's got a question, please just interrupt and shout it out. So we're going to move a little bit into some of the terminology. The needle, needle anatomy. So this is what the actual suture needle is. And some of the important terminology to be familiar with is the eye or the swage. That's where the thread comes in and connects with the needle. Then you have the needle length. So when you're looking at a pack of sutures, it'll tell you what the length of the needle is. It may be like a 9 millimeter, very small suture with 6-0 Proline, or a 3-0, which is a much larger needle. So we've got the needle point. These are some common types of needles, and we have our conventional and reverse cutting. I'll be honest, I didn't know the difference between these until just a couple of years ago. I would always just, suture with whatever was available or whatever, somebody grabbed. And the reason that these are named like they are, it's because of the apex of the needle. You can see these little triangles down here. And on the conventional cutting, we have the cutting surface, that sharp apex there of the triangle. On the concave on the inside portion of the needle. And the reverse cutting, that same cutting surface is on the outside. Now, you may ask, why is that important? And I think, in all fairness, it probably is more applicable to surgeons. But if you look at the cutting needle tissue defects with the reverse cutting, you can see that the apex of that triangle is on the outside, as opposed to the conventional cutting, that apex is on the inside. Now, imagine if you're suturing delicate tissue or you're having to close a wound that has a little bit more tension, that cutting defect may lead to the suture material itself actually cutting through the margins of that wound. So that's why it's important to at least be familiar with this concept of the conventional versus reverse cutting needle. Now, some other terminology that we need to be familiar with, and I've got the two main ones here circled in red. Elasticity, that's the ability of the suture to stretch and recoil. And I think that you see this mostly with the Ethylon, the typically black colored suture. Whenever you're tying it, it's got a little bit of stretch that's associated with it. And I think that that helps secure those knots a little bit better. The other one is memory, and that's the ability of the suture material to return to its shape after it's manipulated. And we see this often with like a large suture material, such as a 3O Prolene. And I'm sure you've all experienced this. You take the suture out of the pack and it stays wound up, and it makes it very difficult to deal with. So memory is something to be familiar with. And a little trick here that we've got on this next slide. I'm not going to play the video, but something that you can do to make your life a lot easier is whenever you take the suture out of the pack, simply run it through your thumb and your middle finger or your index finger and just kind of rub it along your fingernail, and that will help straighten it out. And it makes it so much easier to work with. Another little helpful tip is if you're only putting in 2, 3, or 4 sutures, you really don't need the 2 feet of suture material that comes in the pack. You can cut it in half. It just makes it a lot easier to work with and a lot easier to manipulate. So straightening it out and cutting it just to have a more workable length of suture material. All right, so back to the case. How do you approach a wound like this? So when I saw that, the things that are going through my mind are, wow, that's kind of gaping open. And how am I going to bring the edges of that wound closer together so that I don't have all this exposed raw tissue underneath, so that I can give this wound the best chance for healing? So I want to start thinking, okay, well, could I use staples? Well, I don't think staples will bridge that gap. So I'm going to have to come up with something else. You always want to think about associated injuries. You know, did your patient fall and you see the obvious injury, but did they hit their head? Do they have any neck pain? Are they on any anticoagulants? Do they need any advanced imaging that may not be available? So don't get distracted by the wound that you see and overlook any other associated injuries. You know, you want to always ask yourself, do you have any need for imaging? And for this particular case, I knew that I didn't need to get any x-rays. There was no, concern for a foreign body. She was able to stand and bear weight. There was no deformity. So I knew I didn't need any imaging. Now for anesthesia, we pretty much have 2 choices: lidocaine or lidocaine with epinephrine. I think that's probably what most of us use. I'm a big believer in using anesthetics with epinephrine because it allows for a longer duration of action. It also helps with bleeding, and it also gives you a visual as the tissue blanches because of the vasoconstriction. So I'm a big fan of using epinephrine. Irrigation, we'll talk a little bit more about later, but we want to, the solution to pollution is dilution. So we really want to irrigate this wound out well. And then the supplies that I'm going to need for this, my single-use laceration kit. I'm also going to grab some steri strips, and we'll talk about why here very shortly. And then I want to have a large suture with a large suture needle that I can really grasp large bites of tissue. So I chose 3O Prolene, and we'll get into the repair here shortly. All right. I don't know what stage of practice all of you are in. Some of you may be completely new to acute care medicine. You may have never sutured before. Some of you may be veterans and can do this in your sleep. But I want to talk about some of the basics, because in the work that I do, the workshops and things like that, I see people who have been doing things for a long time and they've been doing them incorrectly. So, and this goes for myself included, just because we've been doing something for a long time doesn't always mean that we've been doing it correctly. So I just want to touch on a couple little points here. Very important to, if you are early on in your practice, in your experience, to really get in the habit of not touching the suture needle with your fingers. Really try to use your instruments like the tissue forceps to manipulate and reposition your needle as you're using your needle driver. All right, we'll talk about that here shortly. So for instrument handling, we really want to visualize our instruments as being an extension of our hands. So for the most part, if you are either right or left-handed, you're going to be using your needle driver in your dominant hand. I do speak with some left-handed people who have just adapted and they use the needle driver in their right hand. And then your non-dominant hand, for the most part, is going to be used for your tissue forceps. And you want to grasp these with your thumb and your index, possibly even your middle finger here. And the tissue forceps are used to stabilize the tissue, to kind of position the tissue so that you can easily introduce the needle into the tissue. And as you are grasping your needle, as you can see here in the bottom middle, you want to grasp the needle not too proximal, not too distal. And I really try to shoot for about 20 to 30% down the length of the needle, kind of at a perpendicular angle, and using my tissue forceps to introduce the needle at about 90 degrees. And then it's really just a twisting motion. It's kind of like you're grabbing a doorknob and turning it. So you can really allow the needle to go its natural path, that curve of the needle as it goes through the tissue. So another important thing to mention is just the whole concept of body mechanics. You want to make the instruments work for you, not against you. So positioning of the patient, so that you're not having to contort your body all the way around. Make sure that the patient's positioned properly and that you are positioned properly, that the bed is at a proper height, because there's nothing that's worse than having a big lac early in the day and then your back or your arm is hurting for the rest of the day because of your body mechanics. So just a couple little pointers there on instrument handling and body positioning. Now, knots are really important. And again, with a lot of the workshops that I do, I see people who are doing things improperly because they were just never taught right or taught correctly. So what we're trying to do is create a squared, secure knot. And that is done with what is called the surgeon's knot, where essentially you are putting your initial tie is 2 loops around the needle driver. You grab the tail and you pull it across, and you can see this in the bottom image. We've got the black thread and the white thread. So your first throw is 2 wraps around the needle driver. You grab the tail and you pull it across, and then all subsequent throws are 1 wrap around the needle driver and you grab the tail and you pull it in the opposite direction. So when done correctly, the image up here on the upper right, you can see how the black and white threads kind of create this back and forth movement. And when you secure that, that all comes down nice and tight, nice and secure, and it's less prone to unraveling. What I see people doing a lot is what we see in this incorrect image, where they have their thread and they're essentially doing a throw, but they're pulling the tail in the same direction every time. And what that does is basically just creating a loop around your dominant thread that has the needle attached to it. And what you end up getting is a very insecure knot that is prone to unraveling, which you see here on the left, which is done incorrectly, as opposed to the right, which is nice, tight, and secure, and it's not going to unravel. So again, just some introductory basic things that some of us may have overlooked. But whenever you're practicing this or you're doing it on a patient, what I do myself is I'm saying it in my head: left, right, left, right, left, right, going back and forth, making sure that I'm going in opposite directions each time. All right, so we're going to switch gears a little bit. And I mentioned in the introductory slide that we're going to talk about the digital block. Although I can't see everybody's responses here, I imagine that some of you have probably seen a finger laceration. Fingers get injured all the time, and it's probably one of the more common sites for lacerations. And in order to manage these, we have to anesthetize them. Now, personally, up until probably 2 years ago, I had always done the technique where we insert the needle on both sides of the finger, and it's a 2 injection technique. It's 2 sticks, it hurts more, and it takes a little bit extra time. So I had posted something on my Instagram about doing a digital block, and somebody had commented, "Hey, have you ever seen the transthecal or single injection technique?" And lo and behold, I had not. So I looked it up, and shortly thereafter, a patient came in with a finger laceration. So I researched it, watched a video how to do it, and I did it 30 minutes later, and it worked really well, and I've not gone back. What we're trying to do is with all digital blocks is to anesthetize the digital nerves, and we have them on the volar or the palmar surface and the dorsal surface. So what you can do is this single injection technique where we're coming in here and we're going down towards the bone, withdraw a little bit, and then what we're going to do is we're going to inject in this area. And what happens is that anesthetic gets into the tissue sheath or the tendon sheath, and it diffuses around, and it provides excellent anesthesia. This is the landmark. It's very simple. If you look at the palm of your hand, you see the little crease right here at the base of the MCP joint. That's your landmark. It's very simple. You just go right in the middle. Of course, you want to wipe it down with an alcohol swab. Go in at about 45 degrees. You can touch the needle to the bone, withdraw just a little bit, aspirate to make sure that you're not in a blood vessel. And then you're going to instill maybe 3 or 4 mLs of your anesthetic. This is great for lacerations of adjacent fingers, like somebody cut their finger on a knife or multiple fingers on a knife or on glass or hedge trimmers or something like that. So it's a great, easy and fast way to be able to anesthetize adjacent fingers. All right, so that's with the digital block. We're now back to the closure for this particular patient. So you can see steri strips here. So what's the deal? Why do we have steri strips? Well, elderly patients have thin skin. And if I were to just put sutures in here, there's a good chance that they're going to rip through. So I had heard about this technique, but had never had an opportunity to do this. And since then, I've done it probably half a dozen times. But the theory here is to use your steri strips to bolster and reinforce the tissue so that I can put sutures in, and that suture material is not going to tear through the skin, and it allows me to apply tension. Now, this was not deep enough that I could put in deep sutures. It was just these tissue edges really had separated. So I took my benzoin glue and painted that along the margins of the wound, applied steri strips across, and then I put in a series of horizontal mattress sutures. And I put my first one here, roughly in the middle to kind of bring things together and see what the alignment was. And then I just did a series of horizontal mattress sutures all the way across. And you can see how much I was able to bring that tissue together. There's only a very thin margin of fresh exposed tissue, much better than had I chosen another technique. So we'll talk a little bit more about this here in a little bit, but I think you can appreciate how good of a closure this ended up coming out. All right, so we're going to talk about some myths and bad practice habits. Now, all of us were trained with, under mentors in school, in practice, and we really take what our mentors tell us to be, kind of gospel. Well, I was taught this way, so that's how I'm going to do it. And we're going to talk about some of these myths here and try to bust them a little bit. The first of which is the sterile field. Now, some of you may have come from a surgical background where sterility and a sterile field is very important. We're working in urgent care, we're working in the emergency department, and it's just not really applicable. Now, because it's a dirty wound. You had dirty non-sterile skin to start with, you have an injury, and it's just a dirty wound. So me putting on sterile gloves or having a gown on is not going to make that wound any more less, it's not going to make it more sterile. So you want to use common sense, you want to clean, you want to irrigate, use the drapes for your instruments and to keep the patient's hands and clothing away from where you're working, but a sterile field is just not achievable. Another myth is that we have to use sterile water, saline or just sterile water. And I'm just here to share with you that we can use tap water. Sterile solutions do not have any better infection rates than tap water. So tap water is also cheaper. The patient can stand at the sink. It gives you a little bit of time. It has them involved with the process. You can give them some gauze and they can sit there after it's been anesthetized and they can wipe away any dried blood. They can irrigate it for a minute, and it's a great way to be able to irrigate, and it saves a little bit of money. It's $1.50 for a bottle of saline, but with multiple clinics and multiple lacerations, it does start to add up a little bit. You can also just take that tap water and put it in the little basin that comes with your instrument kit, and then use a syringe and splash guard for irrigation. Sterile gloves. This is another one. This is a little bit more of a hot topic. Again, a lot of people who come from a surgical background are really, sometimes more hardcore about this. Again, the whole concept, it's not a sterile procedure. Sterile gloves, if you want to use them, it's totally fine. Some people just like the fit and the feel of them better, and that's totally fine, and that's acceptable to use them for that reason, but you don't have to. The same thing with the sterile water. Multiple studies show no difference in infection rates with clean versus sterile gloves. You can use the gloves that come in the box. Now, this one does have a little bit more significant cost savings associated with it. At my hospital, a pair of sterile gloves is $2.30 versus 7 cents for the gloves that come in the box. Same goes for abscess. You don't have to use sterile gloves for drainage of an abscess. And that really can add up quite significantly over time from a cost savings perspective. All right, another myth. If I could see a raise of hands, I bet that it's going to be quite high. But who all has heard that myth of the fingers, nose, penis, and toes for epinephrine? Yeah, I had for quite some time. Yep, Crystal, I hear you. The same way. So just to let you know, that's not true. All right. Orthopedic surgeons, plastic surgeons, ear, nose, and throat, and urologists use epinephrine containing anesthetics all the time on those appendages, and it's fine. It's kind of an interesting story how that myth came to be. About 100 years ago, there was a series of patients who had hand or finger procedures and surgery, and they had anesthetic, I think it was Marcaine, that had epinephrine in it. And there were all these cases of digital necrosis. Fingers ended up, being amputated because the finger died. And they thought that it was because of the epinephrine. When they looked at it closer, the preservative that was in the anesthetic degraded or something happened, and it drove the pH of that anesthetic solution down to 1. So essentially what they were doing is they were injecting acid into the fingers, and that's where the digital necrosis came from. So unfortunately, that myth became legend, and that legend became truth. And that's one of those myths that's been propagated over time. The benefit of using epinephrine is it allows for a longer action of the anesthetic. And equally as important from our perspective is it helps control the bleeding. Now, we will talk a little bit about finger tourniquets shortly, but bleeding in finger injuries is very important to control so that you can get a good look at the field of the injury and make sure that everything is intact, there's no foreign bodies. So those are the two main things, is that it prolongs anesthetic duration and it helps control bleeding, and it is safe to use. All right, just a couple things. I can't tell you how many times I've walked into a room and I see a patient with their hand soaking in a tub of betadine or chlorhexidine. Now, those solutions, it's kind of controversial. You see it more in the surgical aspect. Orthopedic surgeons like to use betadine. There's no studies that show there is any superiority to betadine or chlorhexidine versus water when it comes to wound cleansing. You can use those. They're felt to be safe, but there's no real benefit in infection prevention compared to very copious proper irrigation with water alone. The next slide is pretty much the same thing. The last thing to mention is hydrogen peroxide. And I'm sure that you all have seen patients who come in and you probably have seen this as well. You've got a wound. It may have been like 2 weeks ago, and they're like, it's just not healing. It's not getting any better. And it's got this real shiny, glossy appearance to it. And after a while, I was just like, you've been putting hydrogen peroxide on that. They're like, oh yeah, every day I've been, scrubbing it with hydrogen peroxide. And the hydrogen peroxide is actually very tissue-cidal, and it prevents granulation tissue formation. So hydrogen peroxide does not have any role with acute wound management, and encourage your patients to not use it at home as well. All right, so irrigation. I'm a big believer in this topic. The solution to pollution is dilution. We talked about that a little bit earlier. I mentioned that little phrase. Our goal here is to provide enough water and enough pressure to get rid of this biofilm. This is a polysaccharide film that starts very early after a wound is created. It's got bacteria and all these polysaccharides that just create this biofilm. So what we're trying to do is dilute that out with volume, 50 to 100 cc's per centimeter, along with pressure. And that's why you can't just punch holes in a bottle and squeeze the bottle of saline or use a big bulb syringe. I've actually done quite a bit of research on this, and the amount of pressure that's generated by squeezing a big bottle is not anywhere close to what is recommended for proper irrigation. Another little helpful tip is from an efficiency standpoint. Let's say you're trying to irrigate, 500 cc's of water. It's much more efficient to use a 60 cc syringe, 9 times versus a 10 or 20 ml syringe 50 times. All the pushes and pulls of the syringe, it's just a lot faster to use a larger volume syringe. Using the syringe and splash guard, that allows you to generate that pressure. Another thing we talked about earlier, having the wound irrigated out at the sink, that does 2 things. One, it provides more than adequate volume, and it does provide enough pressure to properly irrigate. All right, I know I'm going kind of fast here, but I've got a lot of slides and want to get through as much as I can. So for the documentation here, I'm not going to read this out, but I imagine those of you who are in a clinical leadership or supervisory type role, you all have seen charts where a laceration, all the documentation was arm laceration repaired with suture, something like that. Well, you're not going to get reimbursed for that, and you don't have any leg to stand on if there is a bad outcome. So it's important to be detailed in the description of the wound and your repair. You have to include the location, the length, and the complexity. Now, we need to be reimbursed for what we do. All right. We're not trying to artificially inflate anybody's bill, but if you have a more complex wound that's grossly contaminated, you've got devitalized tissue that you've debrided with scissors, or you're putting in deep sutures, you need to include that in your procedure note so that you can get reimbursed properly. So documentation is very important to do well. These are just some must-have products that I think that we all should have access to. Trauma shears, they're great for cutting off clothing, splinting material, having a good light. There's nothing that's more difficult when you're trying to squint and see what you're doing. So, overhead lighting is very expensive. At my emergency department, we have a very strong LED rechargeable headlamp that we all use and share for laceration and other procedures. That's a great thing that you could have in your work bag and bring with you. A little ruler. There is a ruler that's included on most boxes of gauze, as well as cotton tip applicators. So why should we have a ruler? Well, one of the components for billing and coding is length. So you need to be able to have an accurate way to be able to measure the length of the laceration that you're repairing. Cyanoacrylate, aka Dermabond or glue, tissue adhesive, is just a great way to be able to close a lot of wounds. I'm a big believer in having the large surgical staplers. They just work a lot better than the little finger held, like 5 or 10 shot type staplers. Steri-strips and Benzwin, we talked about on this case with, Steri-strips are just a great way to be able to close low tension wounds and also skin tears. And then finger tourniquets, which we're going to talk about right here. Now, finger tourniquets are important for your finger injuries, and especially patients who are on anticoagulants. These things just bleed, and you want to be able to get a good look, especially if it's overlying a joint, being able to evaluate for extensor and flexor tendon injury. So there are commercially available tourniquets like this one here. They're around $2 to $3 each. But if you don't have those and you still want to apply a finger tourniquet, you can have the patient put a glove on their hand. And let's say it's the index finger that has the injury. You can just tear off the tip of the glove and essentially just roll it down to the base of the finger, and voila, you have a tourniquet. Big thing with tourniquets is if you put one on, you have to take it off. If you do a quick Google search for finger tourniquet, the first things that show up are all the cases of patients who have had accidental injury to the finger because a finger tourniquet was left on. So if you're putting one on, it's your responsibility to take it off. Don't rely on a nurse or a tech or somebody else to do that. All right, so this is our patient, our case that we've been talking about. And I got some good follow-up images. The first one at 2 weeks, this is from the orthopedic surgeon, who was an older gentleman. He was probably in his mid-60s, older than me at least. And he had never seen that technique either. So it was an opportunity to teach somebody else. So he sent me that first image. And at 4 weeks, the patient's granddaughter sent me that image. And you can see that it's healing nicely. And then at 6 months, kind of a funny story. This was at an emergency department that I was doing some moonlighting at. The patient's granddaughter called me out of the blue and said, "Hey, grandma fell and she cut her hand. Are you working today?" And fortunately, I was not. But I said, "Well, can you send me a picture of her leg?" And you can see this at 6 months. You can barely even see the site of the injury. So this really came together very well. And I think that we were able to provide her a much better outcome. So that's the case resolution with the follow-up images there. So we're going to talk a little bit about some advanced techniques and then hopefully get into some of the questions that you all submitted. All right, so we got a bleeding varicose vein, and I've seen a lot of these who have been sent from primary care offices or even a local urgent care. And there's a couple things that you can do, injecting a little bit of lidocaine and epinephrine, applying pressure for a while, sometimes is sufficient. But this little figure of 8 stitch is a great way to be able to control the bleeding for these. Now, any varicose vein is basically a vein that is coming in close proximity to the skin, and you get a little nick in the side of that vessel wall, and it just spurts blood. They can squirt all the way across the room. So just because it is a vein that's coming close to the surface, you can just palpate around the area that's bleeding, and eventually it's going to stop with pressure. So you can hold pressure, and then you can take, I like to use absorbable sutures because they don't have to come back in for removal, and just do a simple figure of 8 stitch. Now, if you're not familiar with that, you're entering the tissue on one side, coming out on the other, and then you're going to go back to the same side that you started on, and then come out on the opposite side, and then you just tie it off in the middle. And it's called a figure of 8 because it looks like the number 8 just tipped on its side. So that's the figure of 8 stitch. This is also great for oozing from dialysis puncture sites. I've seen probably 15 or 20 patients who have come in with oozing of ascites after a paracentesis or a thoracentesis, patients who may, liver disease or cancer, and they've had a procedure done. You can just put a simple figure of 8 stitch in, and they can follow up with their primary care physician, or they can snip it out in a week, or it's just going to dissolve if you use absorbable suture. So great little trick to really make a patient happy quickly. Closure techniques with Steri-strips, we've talked about that in this case. Steri-strips are great. They can be combined with glue. They can be combined with sutures, and they're great for skin tears, elderly patients, to be able to close and bring that tissue back down so that there's not that raw exposed tissue. We just talked about that in the case, so that was a little redundant. Now, these are the fun ones. the more complex injuries, you've got these tissue bridges, flaps, parallel lacerations. And what I try to do myself and talking with people and with workshops is to envision how the wound should come together, because sometimes it doesn't look like it's going to. So there have been times where I've even taken a picture of the wound and I'll go and I'll sit down and I'll kind of draw it out. How's this thing supposed to come together? Sometimes these are going to require undermining to reduce tension, debridement of tissue, and then bringing things together. And sometimes it's going to be a combination of different suture types, interrupted, subcuticular, different mattress variations that we're going to talk about. So parallel shaped lacerations, or lacerations that are in close proximity. These are fun to put together. And, you may see these more probably in the emergency department with intentional harm, people who are cutting. If you've got any lacerations that are in close proximity, the technique is essentially an extended horizontal mattress suture. And what I mean by that is, if you can visualize over here on the right side, if I'm starting here on the proximal wound, I'm essentially just threading the needle and thread through the dermal layer, deep all the way down, and I come out on the distal end. I come across, and then I come back in the opposite direction, threading the needle and thread through those little tissue bridges or tissue islands, and then I'm going to close it on the same side that I started on. And you can do these in succession for larger wounds. And here are a couple examples. This was a gentleman who was not wearing steel-toed boots, unfortunately, and his foot became intimately involved with a tractor bucket. And you see this kind of macerated area up here. So what I had done for this part up here, this tissue was just too thin and friable, and it wouldn't really hold two sutures there. So I just threaded that tissue all the way across, came up, and then brought it up here to where I started and tied it off there. Here's another example. This was an eyebrow laceration. You see this little tissue bridge that came in right here. I didn't want to cut that out, but it's too narrow to be able to support a lot of suture material in there. So I did the same thing and basically just kind of threaded it through, came across, tied it off, and it came together very, very well. So this is just another little trick that you can have in your arsenal to be able to approach some of these more complex wounds. All right. Just to close out that one case discussion, and the reason I include that, I've got a dozen of these case presentations in the laceration course to kind of go through the medical decision making. And for each one, these are the types of questions that I ask. Was there a need for imaging? Nope. The type of suture that I used was that combination of stereostrips and 3-O-proline. My biggest concern was just being able to get that tissue back together. With her being elderly, lower extremities do have a higher risk of infection, and just there was so much exposed tissue. This is a case where I decided to provide some antibiotics. Also wanted to make sure that she had somebody that she could follow up with. That's why it's very good to have relationships with local specialists like orthopedics or wound specialists. And for this particular case, I don't think that there was anything in particular that I could have done differently. Plenty of things could have gone wrong, but we were fortunate to have a good outcome. And some of the cases that I do talk about, there are things that I could have done differently. And I'm the first to admit that I've still got a lot to learn with this. And that's where we learn, is by having, outcomes that aren't ideal, and, just being willing to talk about them and learn from them. All right. So that kind of closes out the main portion. And now I'm going to answer some questions. These are the ones that were actually submitted. So I'm going to run through these. Somebody had asked, making suturing less traumatic for peds. Numbing abscesses. All right. So things that can be utilized for children, having a distractor, whether that's a patient or a parent, a sibling. Everybody's got an iPad or an iPhone now. So, using those type of things as a distractor. You can place ice on a wound. There are these little buzzy distraction devices that are used for, vaccinations and things like that. It kind of serves as a little bit of a distractor. Another thing is a pillowcase cape, which I'll show you in a minute. Other thing for children is really the importance of topical anesthetics, and that's for both lacerations as well as abscess. Buffered lidocaine is another thing to be familiar with. This is the little pillowcase cape. This is my son a couple years ago. And this is a way to, the papoose board is just a very obtrusive, intimidating piece of equipment that I don't really think is utilized anymore. But this is something that you can do to help immobilize a young patient's arms, is put their arms back behind them into a pillowcase. And then when they lay down, they're kind of stuck. They can't move their arms. So that's a good way to consider immobilizing arms and keeping them out of the way if you're trying to repair a little facial laceration. Another question was about dog bite closures. That's a very long topic, but some of the key points are, in general, you can safely close dog bites. That used to be one of those myths that you can't, as long as you're irrigating it very well and you are offering antibiotics, typically would be augmentin for dog bites. Cat bites, on the other hand, we do not suture. They're filthy, they're disgusting, and they will get infected. Another thing with dog bites is to trim any jagged edges, to debride any devitalized tissue. But it is safe to close the majority, because we are concerned, especially if there's any dog bites on the face. The cosmetic aspect of it is very important. So it is safe for the most part to repair primarily with sutures. All right, so lacerations in very hairy places. And I saw this question, it kind of made me giggle because in my course, I do have a slide that says hairy places. And when we're dealing with the eyebrows, chest hair, the scalp. Now, in general, we are told, and it's not a good practice to shave with a razor. That induces additional micro trauma to the tissue. Theoretically, there's an increased risk of infection. I haven't seen any studies that really evaluated that, but in general, we don't shave. You can trim some of the local hairs, and I've got an example of that here shortly. For the scalp, I'm a huge fan of staples, especially in kids. Staples, and they can be utilized pretty much anywhere except for the face, the hands, and the feet. So staples, I think, are underutilized, and it's a great way if you've got a very hairy area to be able to bring things together. The blue colored suture, especially in somebody who has dark hair, do your colleagues and whoever it is that removes sutures a big favor and try to use the blue colored suture. It makes it a lot easier to visualize, and also leave the tails a little bit longer, like if it's in the mustache, on the lip, and the goatees, eyebrows, and things like that. Try to leave the tails of the suture thread a little bit longer so they're easier to identify and grasp whenever it's time for removal. Lacerations with nail involvement. Finger lacerations are tricky. They can be, for sure, and we see a lot of them. So with nail involvement, it kind of just depends on how much involvement there is. It's advised to not really do a lot of aggressive trimming. Most are going to do well on their own. You want to look for the subungual hematoma. If that hematoma is larger than 25% surface area, you do need to trephinate. I think most places probably have the little electrocautery thing where you can put either 1 or 2 holes in the area of the hematoma and allow for drainage. We don't, if the nail is intact, you're not going to want to remove it just to evaluate. You can always have them follow up with a hand surgeon. This is a really great blog. I'll see, I can't really put it in the chat. So the NUEM blog, Nail Trauma, is a really good article on a lot of different finger injury specific questions. I just found that earlier today when I was putting this together. But yeah, finger injuries, it takes reading, it takes experience, and just being familiar and comfortable with different presentations. There was a question about, let's see, actually that part I need to remove. All right. Technique to suture laceration that has a flap, and I'm going to talk about that on the next slide. Again, envisioning how things coming together, reducing tension with deep sutures. And this slide right here is how I approach the corner shaped lacerations, the flap, V-shaped, Y-shaped, and even over here on the right side, you have kind of like the inverted P symbol, all these stellate type laceration. So how we can approach these is with a modified mattress technique. So essentially what we're doing is we're going to start here, and then we're going to come out the dermal layer, and then I'm going to grab this little floppy end and put the suture and the suture thread through that dermal layer of that floppy end, come out on the same side that I started. And when you tie that off, it just brings the tissue together, and then you can go and repair the remainder of the laceration. Same concept if you have the Y shape starting on one side and just kind of bringing the apices of all of those wounds together. So I use this technique very regularly, and it works really well. When you see a large laceration, like, oh my gosh, how in the heck is this going to come together? Using this technique really does work well, and I think that you'll get a lot of use out of it. There was a question about the suture types. We already talked about that earlier. This part, I'm just going to delete that and then bring this up. It's hard to answer that really quickly. This is just a little summary slide on a cheat sheet that we send out to everybody. Using your absorbables pretty much everywhere except inside the mouth. The Vicryl and the Zorbable are going to be for your deep closures, and more advocating for it externally. If a patient is unreliable, you probably see this more in the emergency department than in the urgent care setting, but somebody who may be homeless, social determinants of health, just kind of concerned about them coming back, maybe a good time to use an absorbable suture. And then the different needle sizes. I like working with the small needles because I feel like I'm able to get better control, especially on the face, and then working like in web spaces between fingers and toes. So having smaller needles for me is more preferable. All right. Multi-layer closures and other types of things other than your simple interrupted. So whenever you've got a large gaping wound and you're concerned about the tension, that's when you want to think about putting in a deep suture with absorbable like Vicryl. And that deep suture, depending on how long the space is, you can put in a couple of interrupted, you can do a running suture or a figure of 8. It's important, and I don't have a slide on it here, we talk about it in the course with some videos, is you want to start deep, come up, and then tie your knot down deep. A little bit more difficult to explain just on a slide. But those are the time, excuse me, that's the main thing. If the wound is gaping open and there's going to be a lot of tension in it, that's when you want to consider putting in your deep sutures. All right, let's see here. So best practices for lip lacerations and ears, I'll talk about here in a second. So for lips, this is a topic that is near and dear to my heart. I actually did a study, I think it was a year ago, where myself and 2 colleagues called 100 urgent cares across the country, and we posed ourselves as a hypothetical patient with a lip laceration. And what we found was that 45% of the clinics said, no, you need to go see a plastic surgeon. Well, unfortunately, plastic surgeons are not readily available. And in a lot of smaller areas, they don't staff the emergency department. They're not going to come in. They're not available for consultation. So a patient is told that they need to see a plastic surgeon. They show up in the ER and they're expecting that. And that's not an option. So, lip lacerations, that's one of my main goals, is to give people that comfort and the familiarity with managing those. And whenever somebody purchases the laceration course, I designed this suture pad with 3-dimensional lips so that you can get some familiarity. So you can repair these. Now, if it's filleted open and it's got, jagged tissue all over the place, absolutely, you don't need to do that. But for simple lip lacerations, you can repair those in the emergency part, or I'm sorry, in the urgent care setting. And we'll get into the stepwise approach. So the first important thing is to align the vermilion border, followed by the muscular layer, and then the inner portion of the lip, the wet mucosa, and then lastly, the outer dry layer of skin. This is where facial nerve blocks come into play and are a great tool for you to be able to anesthetize without distorting the anatomy. You want to irrigate them out very well. For the deep sutures, you want to use an absorbable suture. And for the external part, you want to use a non-absorbable suture like a 5-0 or a 6-0 Prolene or Ethylon to be able to bring that together. This is just an example. This is a patient who got hit with a nail and there was a large lip laceration. Fortunately, it didn't go all the way through, but this kind of brings in that question earlier about shaving or trimming hairs. So I just took the suture scissors and trimmed some of the hairs to make it a little bit more approachable and easy to visualize. I aligned the vermilion border, and then we had closure of the orbicularis oris muscle, followed by the dry lip, and then the sutures up onto the face. And this came out really, really well. So those are all the questions that I've got. I just want to run through, if y'all are okay, I'm going to run through a couple things real quick. This is just the introduction to the laceration course. These are all the modules that are included with that. Comes with this free practice suture pad, as I mentioned, a cheat sheet with a lot of little helpful tips that can be laminated. And if you do decide to go through this, it will give you that confidence to manage a lot of things that you may not feel comfortable with right now. My partnership with EB Medicine, we have a handful of different products that are specific to urgent care, with the laceration and EKG course, a reimbursement, billing, and coding. And I've put together an abscess course that's going to be launched very soon. One thing I do want to ask all of you and invite you to is the Facebook group that we've got, where we talk about this kind of stuff. A lot of free educational resources, polls, questions, sharing of foam, the free online access to medicine content. So I encourage all of you to come and join our Facebook group. We'd love to have you, and just want to offer a safe forum for people to come in and ask questions and share cool cases, and just kind of talk about stuff specific to urgent care. So after this webinar, we will send a recording out to everybody. Just keep an eye out for an email either from myself or somebody with EB Medicine. We'll have a link for the replay that you can share with your colleagues, and along with contact information. One last thing that's not relevant to lacerations, but something just to mention to you all is, since you're on the West Coast, the existence of CALUCA, which is the California Urgent Care Association. It's a regional urgent care group that's under the umbrella of the Urgent Care Association. I've been to one of their conferences in Monterey about a year and a half ago. And if you're interested in urgent care medicine and becoming more involved, I really encourage you to take a look at caluca.org and get involved. Really a great group of people and a lot of opportunities for you to get more engaged and more involved with the urgent care industry. We do have a conference in 1 month with the Urgent Care Association, which is going to be in Las Vegas. If you're interested, we'd love to have you there. Really a great conference. And then that wraps that up. This is my contact information. You can find me on LinkedIn. Follow the laceration course on social media, EB Medicine on social media. But if there is anything at all whatsoever that I can do to help you, don't hesitate to shoot me an email or something on LinkedIn or social media. I'm here to help you in any way that I can.